Okay, good morning again. Now we are moving from vomiting to diarrhea. So diarrhea is one of the most common gastrointestinal symptoms we see in our day-to-day clinical practice. It is especially important in children, elderly patients, and patients with poor access to safe water and sanitation. In simple terms, diarrhea means passing loose and watery stools more frequently than normal. But from a physiological point of view, diarrhea occurs when there is an imbalance between intestinal absorption and secretion. Either the intestine secretes too much of fluid or it fails to absorb enough water and electrolytes. Or the intestinal motility becomes fast. The major danger of diarrhea is not only the loose stool itself, but the loss of water and electrolytes, especially sodium, potassium, and bicarbonate. This can lead to dehydration, metabolic acidosis, hypokalaemia, and shock in severe cases. So in this part of the lecture, we will focus on mechanism of diarrhea, the biochemical changes, the cholera toxin. We will go a bit deep into cholera toxin, and the importance of oral rehydration solution, and I will be explain the practical clinical points of oral rehydration therapy. Now let us define diarrhea clearly. Diarrhea is usually defined as a passage of loose stools or liquid stools 3 or more times per day. But we must remember that the normal bowel habit differs from person to person. So if a person passes loose stools more frequently than their usual pattern, we can also consider that as diarrhea. So it is individual dependent. You cannot say a person passing small amount of stool 5 or 6 times per day, maybe due to stress or something. It is diarrhea. Okay, so define the definition exactly. At the same time, frequent passage of formed stool is not diarrhea. Also, in breastfed babies, soft or pasty stools can be normal. So we should not overdiagnose diarrhea in them. From a physiological point of view, yeah, from a physiological point of view, around 9 liters of fluid enter the gastrointestinal tract every day. About 2 liters come from the diet and 7 liters from secretion. They include saliva, gastric juice, bile, pancreatic juice, and intestinal secretion. Normally, more than 98% of this fluid is reabsorbed, and less than 200 ml is lost in stool. So diarrhea occurs when this balance is disturbed. Either secretion increases, absorption reduces, or intestinal movement becomes too fast. So there is no time for absorption. The result is increased water remaining in the intestinal lumen, producing loose or watery stool. This slide shows the daily water turnover in the gastrointestinal tract. As I mentioned earlier, 9 liters of fluid enter the gut, 2 liters as drinking or eating, and 7 liters as body's own secretion. So I have given the amount of secretion here. So sometimes that may be asked at the exam, especially single best answer type question. Normally, almost all the fluid is reabsorbed. Around 5.5 liter is absorbed in the jejunum, 2 liter in the ileum. 1.3 liter in the colon. Finally, only about 200 ml is lost in stool. This explains why even a small disturbance in absorption or secretion can produce diarrhea. If the intestine fails to reabsorb fluid, or if the secretion increases, the amount of water left in the stool rises quickly. So diarrhea is basically a failure of this normal balance between secretion and absorption. Now let us understand the basic mechanism behind diarrhea. Normally, water and electrolytes go in the both direction across the intestinal wall. Some fluid is secreted into the intestinal lumen and a large amount is reabsorbed back into the body. Diarrhea occurs when this balance is disturbed. There are two main possibilities. Why I am repeating again and again is you should know this very well. It should be on your fingertip because you will be daily you will be seeing patient with diarrhea in the pediatric ward, in the geriatric. There are two main possibilities. First, there may be a reduced net absorption. This means the intestine fails to absorb enough water and electrolytes. This can happen when the intestinal mucosa is damaged, inflamed, or the food is not properly digested and absorbed. Second, there may be increased secretion. In this situation, the intestinal cells actively secrete more fluid and electrolytes into the lumen. Cholera is a classic example of this type. When excess fluid enters the large intestine, the colon tries to absorb it, but the colon has a limited absorptive capacity. Once that capacity is exceeded, excess water remains in the stool and the diarrhea occurs. The key message is simple. Diarrhea happens when fluid entering the colon is more than what the colon can absorb. Now we look at how the intestine normally absorbs water and electrolytes. Water absorption mainly follows osmotic gradient. That means water does not move alone randomly, it follows solutes, especially sodium. When the sodium is absorbed from the intestinal lumen into the body, water follows sodium by osmosis. There are several mechanisms for sodium absorption. One method is direct absorption of sodium through epithelial sodium channels, such as innate channels. This is especially important in the colon. Another important mechanism is for transportation. Sodium can be absorbed together with glucose or amino acid through carrier protein. This is very important because this sodium glucose co-transport mechanism remains functional in many diarrheal illnesses. There is also sodium hydrogen exchange where sodium enters the intestinal cell while hydrogen ions are secreted into the lumen. The most important clinical application of this slide is ORS. ORS works because sodium ORS works because glucose helps sodium absorption and water follows sodium. So even when diarrhea continues, the intestine can still absorb water using this sodium glucose co-transport mechanism. That is the basic physiology behind why we are giving oral rehydration solution which contain glucose. This slide explains the scientific base of oral rehydration solution. So we have seen that. So this diagram shows how sodium chloride, bicarbonate, glucose, amino acid and water moves across the intestinal epithelial cell. The most important idea is that water follows solutes. When the sodium moves from intestinal cell, the lumen intestinal cell When sodium moves from the intestinal lumen into the cell and then into the interstitial fluid, water follows by osmosis. On the luminal side, sodium can enter the cell in different ways. One important pathway is sodium glucose co-transporter. Here, sodium and glucose enters with amino acid and through the sodium hydrogen exchange, where sodium is absorbed and hydrogen is secreted. Chloride absorption and bicarbonate secretion also help maintain electrolyte balance. On the basolateral side, the sodium-potassium pump moves sodium out of the cell into the interstitial fluid. This keeps intracellular sodium low and allows more sodium to enter from the lumen. The key clinical point is oral rehydration solution because sodium and glucose are absorbed together, giving glucose and sodium improve water absorption even during diarrhea. So ORS works by using the normal physiology. Now we'll summarize the main mechanism of diarrhea. Diarrhea can occur through different pathways. The first is inadequate digestion. For example, in lactose tolerant, lactose is not properly digested. It remains in the intestinal lumen and pulls water into the bowel, causing loose stool. The second mechanism is decreased absorption. An example is steatorrhea, where fat is not properly absorbed. The stool may become bulky, oily, foul smelling, and difficult to flush. This can occur in malabsorption or pancreatic disease. The third mechanism is increased intestinal motility. If intestinal movement is too fast, there is not enough time for water and electrolytes to be absorbed. This can occur in functional gastrointestinal disorders. The fourth mechanism is secretory diarrhea. Here the intestine actively secretes excess water and electrolytes into the lumen. Acute gastroenteritis is a common example and cholera is a classical severe example. So diarrhea may result from poor digestion, poor absorption, rapid transit, and excessive secretion. Understanding the mechanism helps us understand the cause and plan of management. Now let us focus on secretory diarrhea or secretory diarrhea, which is one of the most important mechanisms in diarrhea. In secretory diarrhea, there is abnormal secretion of water and electrolytes, especially salts, into the small intestine. Instead of mainly absorbing fluid, the intestinal mucosa starts secreting large amount of fluid into the lumen. Because salts such as sodium and chloride move into the intestinal lumen, water follows by osmosis. So this is what is happening here is opposite to what normally happens. This produces large volume water stools. The important point is that this type of diarrhea can continue even if the patient is not eating much because the problem is active secretion from the intestine. Cholera is the classical example, but secretory diarrhea can also occur in acute gastroenteritis due to bacterial toxin. If the patient continues to pass water stools, they lose water and electrolytes from the body. This leads to dehydration. And if severe, it can progress to circulatory collapse and shock. So in secretory diarrhea, the main danger is rapid fluid and salt loss. That is why early rehydration, especially ORS, oral rehydration solution is very important. Secretory diarrhea can occur due to the virus or bacterial toxin acting on the intestinal mucosa. One common viral cause is rotavirus. It is especially important in children. Rotavirus damages the intestinal epithelial cells and interferes with normal absorption. It can also increase secretion, leading to watery diarrhea. The main danger in children is rapid dehydration. Bacterial toxins are another important cause. Examples include toxin produced by Escherichia coli and Vibrio cholerae. These toxins act on bowel mucosa and stimulate secretion of electrolytes and water into the intestinal lumen. As a result, the patient passes large amount of water in stool. The key point is that secretory diarrhea, the intestine is actively losing water and salt. So even if the patient stops eating, diarrhea may continue. That is why treatment should focus on fluid and electrolyte replacement, especially in the form of ORS. Now we will discuss the action of cholera toxin, which is the classical example of severe secretory cholera. Diarrhea. Cholera toxin is produced by Vibrio cholerae. The toxin has two important parts, the B subunit and the A subunit. First, the B subunit bind to the receptors on the enterocyte, mainly on the intestinal epithelial cell surface. After binding, the toxin enters the enterocyte by endocytosis. Inside the cell, the A1 fragment becomes active. It activates the G protein, it stimulates adenyl cyclase. Adenyl cyclase produce increased amount of cyclic AMP. High cyclic AMP level open chloride channels, especially CFTR channels. As a result, chloride ion moves out into the intestinal lumen. Sodium absorption is also reduced and the sodium remains in the lumen. Where sodium and chloride go, water follows by osmosis. The large amount of water and electrolytes into the bowel lumen, producing profuse watery diarrhea. This diagram visually explains the same mechanism of cholera toxin. First, the Vibrio cholera toxin comes and it's bind with the GM1 receptor and it goes inside the enterocyte. Then it activates the adenyl cyclase, G protein pathway, and chloride comes out, and the sodium also comes out. The chloride and sodium are found outside the intestinal, so water follows by the osmosis. Water is found in the lumen, so it comes and causes profuse watery diarrhea. These actions of the cholera toxin is stepwise manner shown in this picture. Vibrio cholerae reaches the intestinal lumen. The toxin has A and B subunit. The B subunit bind to GM1 receptors. This binding helps the toxin to attach firmly to the enterocyte. Second, after binding, the toxin enters the cells and activates the adenyl cyclase. Then it produces cyclic AMP. Cyclic AMP activates protein kinase A that stimulates the chloride channel. So chloride comes outside. Finally, because of the sodium and chloride remain in the intestinal lumen, water follows by osmosis. This causes profuse watery diarrhea. The green antibody shown in the diagram remained as prevention, and immunity can reduce the toxin action. But clinically, most urgent treatment is rehydration. Why I am repeating rehydration and I am explaining in depth about the cholera toxin is, it is usually commonly asked question. You should be able to explain the pathophysiology behind cholera toxin causing diarrhea. So now we will discuss the main consequences of diarrhea. That is very simple. Diarrhea stool is not just a water. It contains important electrolytes such as sodium, potassium, chloride, and bicarbonate. So when a patient has watery diarrhea, they are losing both fluid and salt from the body. It can cause dehydration. As you know, the more potassium bicarb is loose in the diarrhea, we will get metabolic acidosis. Okay. and hypokalaemia. So among all these, dehydration is the most dangerous. In water diarrhea, what will happen is water diarrhea, fluid is not replaced. The circulating blood volume reduces. This is called hypovolemia. And when the blood volume falls, the heart has less blood to pump. As a result, blood pressure coming down. Tissue perfusion become poor, and the vital organs such as brain, kidneys, and heart may not receive enough blood flow. If the dehydration becomes severe, it can lead to cardiovascular collapse. Clinically, we may see fast pulse, cold extremities, weak peripheral pulse, low blood pressure, drowsiness, reduced urine output, and shock. If the treatment is delayed, severe dehydration can even lead to death, especially in infants, young children, and elderly patients. Now we look at the clinical signs and symptoms of diarrhea in infants. You can see the sunken anterior fontanelle, sunken eyes, lack of tears, increased thirst, dry mucous membrane, skin turgor is reduced, tachycardia, and oliguria. Now we look at how dehydration becomes severe as a fluid loss increases. When there is a fluid deficit around 5% of the body weight, only symptoms appear. When the fluid deficit becomes 10% of the body weight, dehydration becomes severe. Hypotension occurs, a feeble and very rapid radial pulse is seen, cold extremities, altered consciousness, reduced amount of urine output, and at fluid deficit exceed 10% of the body fluid. Rapid death from circulatory collapse happen. And you can see the different classification of dehydration depends on degree of body weight loss, depends on the osmolality of the serum plasma, and the depend on water blood level of sodium. And it's again, I have given a nice chart you can go through how what the different categories or levels of dehydration, mild, moderate, severe, how we are going to define from the level of the percentage of the fluid loss. And you can see the clinical features. You can just go through this. It may be asked in MCQs. Okay, you can have a screenshot or something. You can go through that. It is needed for MCQ, it is needed for SCQ, it is needed for you to assess the patient who comes with diarrhea throughout your life. It is very important. Unless you decide which level of dehydration it is, you cannot treat. Your treatment varies according to the level of dehydration. Hope you understand. And again, I have shown you just a chart for more explanation. Just go through this. Now we look at the metabolic acidosis because it is very important biochemical consequence of diarrhea. During diarrhea, especially watery diarrhea, the patient loses a large amount of bicarbonate in the stool. Bicarbonate is one of the main buffers in the body. Its role is to help neutralize acids and maintain normal blood pH. When bicarbonate is lost from the body, the buffering capacity falls. As a result, blood becomes more acidic, leading to metabolic acidosis. There is also a second mechanism. If diarrhea is severe and the patient becomes dehydrated, the circulating blood volume falls. This can cause hypovolemic shock. When tissue do not get enough oxygen and blood supply, they start producing what? More lactic acid. This lactic acid further worsens the acidosis. So in diarrhea, the metabolic acidosis occurs mainly because of bicarbonate loss in stool, and in severe cases, it is worsened by lactic acidosis due to shock. Clinically, severe acidosis may cause deep breathing, the shallow breathing or Kussmaul breathing, lethargy, weakness, confusion, and worsening circulation. Therefore, early rehydration is very important to prevent both dehydration and acidosis. Now we'll see the features of metabolic acidosis that you know. What is the serum bicarb? Normal, it should be lower than that. The pH should be less than 7.35. You know that. So I'm not explaining too much time. But because of the bicarb fall, the arterial pH also decreases. This means the blood becomes more acidic, breathing becomes rapid and deep. This helps to remove carbon dioxide from the body. Since carbon dioxide acts like an acid in the blood, removing more carbon dioxide helps to raise the pH. This is called respiratory compensation. In severe acidosis, the patient may appear tired, weak, drowsy, or confused. Acidosis can also worsen vomiting and make the patient more clinically unwell. And I have explained in detail about the acid base in 2-3 lectures, so it will not be difficult for you to understand the acid base disturbance happens here. So now we'll look at the hypokalaemia. It's the amount of serum potassium become less than 3.5. In diarrhea, as we seen in vomiting, the GI loss is one reason. Another one is because of the activation of the RAS. Okay, so we have seen that enough. We just go through. And the hypokalemia causes paralytic ileus. This is how paralytic ileus looks like in a X-ray. Paralytic ileus mainly occurs due to the hypomobility of the GI tract in the absence of mechanical bowel obstruction. There is no mechanical bowel obstruction, but because of the hypomotility, less motility because of the hypokalemia. Okay, so it leads to fluid accumulation, gas accumulation in the bowel, and you can see the typical X-ray like this. We may give you X-ray like this in OSP. This is paralytic ileus due to hypokalemia. And I will come to the most important part of diarrhea management, rehydration therapy. The first goal is the rapid correction of fluid and electrolyte deficit. This is called rehydration therapy. In simple terms, the patient has already lost water and salt through diarrhea. We must replace those losses as quickly as and safely as possible. After that, we must continue to replace further losses as they occur. This is called maintenance therapy. Because diarrhea may continue for some time, it is not enough to give fluid once only or only at one time. We have to continue giving fluid after each loose stools until diarrhea stops. Fluid can be replaced either by orally or intravenously. Most patients with mild or moderate dehydration can be managed with oral rehydration solution or ORS, because ORS is safe, cheap, effective, and works through sodium glucose co-transport. However, if the patient has a severe dehydration shock, repeated vomiting, you have to give IV fluids. Now we'll discuss oral rehydration solution. The principle of ORS is based on a very important physiological mechanism I have explained to you. Sodium absorption is enhanced when certain molecules are absorbed together with sodium. The best example is glucose. In the small intestine, glucose and sodium are absorbed together through the sodium-glucose co-transport system. When the sodium is absorbed, water follows it by osmosis. So by giving glucose with the sodium, we improve the absorption of the both salt and water. This is why ORS contains both glucose and electrolytes. It is not just sugar water, it is not just salt water. The correct balance is important. A similar mechanism can occur with amino acids, which come from the digestion of proteins and peptides. Sodium can also be absorbed along with some amino acid. This explains why some food-based fluids, such as rice-based solution or cereal-based fluids, can help in diarrhea. Cooked starch breaks down into glucose and proteins break down into amino acid, both helping sodium and water absorption. That's the reason when there's a diarrhea goes on, we ask the patient to have semi-solid foods like kanji, porridge. Okay. So the key message is the ORS works because glucose and other absorbable molecules enhance sodium absorption and water follows sodium. This slide explains why plain salt solution is not enough for treating diarrhea. In secretory diarrhea, if a patient drinks an isotonic salt solution without glucose or amino acid, sodium is not absorbed efficiently because sodium remains in the intestinal lumen, water also remains in the gut. This can increase the volume of stool rather than correcting dehydration. But when we give an isotonic solution containing both glucose and salt, glucose-linked sodium absorption occurs. Glucose carries sodium into intestinal cell through the sodium-glucose co-transporter. One, sodium is absorbed, water and other electrolytes follows by osmosis. This is the reason oral rehydration solution works so well. It does not simply replace water, it promotes absorption of sodium, water, and electrolytes. I am again repeating same again and again because these are common SCQ questions. And you should know about ORS in and out. Now we will look at the composition of reduced osmolarity of OR. So you just go through that. It shows oral rehydration solution, reduce osmolarity content. So I am going to give you one homework. Why there is reduced osmolarity ORS? Why we are using that? What is the need of using that? You have to go and find. That is for your homework. Now we should remember that although oral rehydration therapy or ORS is very effective, it is not suitable for every situation. First, ORS is not appropriate as the initial treatment for severe life-threatening dehydration. You have to give IV, not the oral. Okay? If the severe life-threatening dehydration, straight away go for IV. For that, you should be able to tell it is severe. To tell severe, you know the symptoms for severe. You know the level of dehydration. That's why I have given you a chart. Then in paralytic ileus, ORT, oral rehydration therapy is not suitable. Because in paralytic ileus, the intestine is not moving properly. So oral fluid may not pass or absorb effectively. It may worsen abdominal distension or vomiting. And ORS may not work properly in glucose malabsorption because ORS depends on glucose-linked sodium absorption. So this is uncommon, but if diarrhea worsens after ORS, we should suspect this. Even though ORS is the first line for mild to moderate dehydration or severe dehydration, IV fluids are needed. Now we will discuss when intravenous therapy is needed. Most patients with diarrhea can be managed with oral rehydration solution. In severe dehydration or signs of shock, we can give IV. The purpose of IV fluid is to rapidly restore the circulating blood volume. In severe dehydration, the patient has lost so much of fluid that blood volume falls. This can lead to hypotension, weak pulse, cold extremities, poor urine output, altered consciousness, and circulatory collapse. In this situation, ORS alone is not enough initially because the patient may be too weak. Therefore, IV fluids are given first to correct shock quickly. Then for the maintenance, you can use ORS if the patient is okay. So there are a few acceptable solutions: normal saline, Ringer's lactase, half standard Darrow solution, half normal saline with 5% or 10% glucose. You will see these solution when you are going to the clinic, and you have to know in and out about each solution. What are their content? How much sodium is there? How much potassium is there? If you take the Ringer's lactate, it doesn't have what? It doesn't have glucose. It only has sodium, potassium. The normal saline doesn't have potassium. It only has sodium and chloride. By looking at these chart, you have to remember what solution contain what molecule or what are the composition of these solution. At least you should know, you should by heart the composition of Ringer's lactate, normal saline is must. Now we are going to discuss an important practical point. Which solution should not be used alone for severe diarrheal dehydration? Plain glucose solutions such as 5% dextrose or 10% dextrose should not be used as the main fluid for diarrheal dehydration. The reason is simple. Plain dextrose provides mainly water and glucose, but it does not provide the electrolytes that the patient has lost in diarrhea. In diarrhea, the patient loses sodium, chloride, potassium, bicarbonate, and water. If we give only dextrose water, it will not effectively restore the extracellular fluid volume. So it does not properly correct hypovolemia or shock. Also, because it does not contain electrolyte, it cannot replace sodium or potassium losses. It cannot help correct acidosis due to bicarbonate loss. So in severe dehydration, we need appropriate IV fluids such as normal saline or Ringer's lactase, depending on availability and the protocol that is being followed in that particular ward. Plain dextrose alone is not suitable for initial resuscitation in diarrheal dehydration. So now we'll discuss about the home remedies or home-based fluid for diarrhea. You know that. The best one is ORS that is freely available in the shops. If ORS packets are not available, what you can do is in home, you can use king coconut water. It provides fluid and some electrolyte, especially potassium. Adding a small amount of salt help to replace sodium. So what you can do is you can get a king coconut water, put some salt, then you can ask the patient to drink. Another useful option is porridge. I told you earlier, such as rice, kanji. Porridge provides water, some salt if added, and starch. Cooked starch can be broken down into glucose, which helps sodium and water absorption. The key message is ORS is the best home fluid. If it is not available, go for king coconut, salted king coconut water, and the porridge. So to conclude the section, we discussed diarrhea, its mechanism, consequences, management. The main idea that diarrhea occurs when there is an imbalance between intestinal secretion and absorption. And we have discussed about secretory diarrhea, especially the action of cholera toxin, where increased cyclic AMP open chloride channels, forcing sodium and water to move into intestinal lumen, causes dehydration. The most important treatment is rehydration, ORS, other solution we have seen. Okay. So when you are managing diarrhea, our priority is simple. First, assess dehydration early. Tell what level of dehydration. Then replace fluids and electrolytes. Immediate replacement. Then maintenance therapy. You have to identify patient who need urgent care. That is very important. Thank you very much. As I always say, may peace be upon you, peace and love. Thank you for your attention. As I mentioned, this topic is very important every day in your life. So never forget diarrhea, that management, vomiting, that management. Thank you very much.